Hi, my name is Amanda McHale, and I'm going to be talking to you today about anxiety disorders and Peplau's theory of anxiety. According to the American Psychiatric Association and the American Psychological Association in our Paris textbook, um, people with anxiety were previously considered to be those who were just kind of warriors, but they were still considered to be well and relatively normal. Nowadays, anxiety is considered to be a major psychiatric disorder that causes great distress, impairs function, and is associated with increased morbidity and mortality. It's the most common mental disorder that affects about 30% of adults at some point in their lives. And it's an emotion that is characterized by the following. People often have worried thoughts, physical symptoms such as tension, increased blood pressure, rapid heart rate, trembling, sweating, intrusive thoughts or concerns that regarding the future, and avoidance of certain situations. In order to be diagnosed, the anxiety or fear has to be out of proportion to the actual situation. It is inappropriate or hinder the ability to function normally. Again, it's important to rule out anxiety that is caused by medical conditions, substances, or medications. The most common anxiety disorders are generalized anxiety, social anxiety, acute stress disorder, PTSD, and OCD. And in any given year, the prevalence looks like is most common. Social anxiety disorder is more common, or specific phobia disorder. Then you have the 2 to 3% prevalence rate of panic disorder, 2% agoraphobia, and 2% generalized anxiety disorder. So for starters, I'm going to be talking about phobic disorders. This involves a fear of specific places, activities, situations, or objects. It is often characterized by a very persistent, unreasonable fear that is triggered by the presence of a situation or object with a desire to avoid that situation or object. The feared stimulus always causes an anxious response, and individuals recognize that their response tends to be pretty excessive or unrealistic. And by trying to manage this fear, there's continued avoidance, and this often compromises personal goals, vocational goals, and social functioning. So there's three components to phobia. There's always the anticipatory anxiety due to thinking about possibly experiencing the feared stimulus. The fear is always geared more towards the outcome that will result from having contact with the object or being in that specific situation. And avoidant behaviors is often used to prevent the anxiety associated with the fear. Phobias can be classified as the following: fear of animals, fear of heights, which are environmental. That includes thunder, fire, water, or storms. Situational phobias include flying, fear of tunnels, elevators, driving, or being in enclosed spaces. There is the blood injection injury, where people are afraid of being injured or they don't like the sight of blood, and will go to sometimes extreme avoidance to not have to deal with those things. And there's other phobias that involve choking or vomiting in children, fear of loud sounds or strangers. So epidemiology in regards to phobias, they occur twice as often in women than men. There is a strong genetic component regarding the blood injury injection phobia. Maladaptive cognitive functioning often plays a role. A lot of times people have negative self-statements or unrealistic thoughts about the consequences of being exposed to the situation or object. Sometimes the development of phobia is associated with brain trauma or head injuries. The biological basis of phobias are not very well understood. There's the theory that there's a dysfunction in the neural circuitry involved with attention, and there's an overestimation of danger of the feared stimulus, or deficient emotional regulation in regards to that stimulus. Areas involving the brain are the thalamus, prefrontal cortex, and anterior cingulate cortex. Basically, the idea is that there's decreased activity for the ability to regulate emotion in the ventromedial prefrontal cortex, and there is increased activity of the expression of fearful responses. Basically, you have an exaggerated response to a certain stimulus, and that is, the idea of that is that's in the dorsal anterior cerebral cortex. There is an increased activity of a fearful response in the amygdala, increased activity of the insula, which is responsible for registering disgust. Clinical presentation. People often don't seek treatment. A lot of times they attribute their fear or phobia to just being part of their personality. They kind of minimize it and just try coping with the situation by being avoidant. Two sets of symptoms are manifested following the exposure or anticipation of the exposure to the feared stimulus, and that includes SNS activation and, as I said already, avoidance behaviors. Sometimes if they're unable to avoid the stimulus, such as like social anxiety or social phobia or speaking in public, the person will tolerate it with increased anxiety but leave as quickly as possible when they are able to, and they're actually pretty miserable having to tolerate these situations. You can review the CNS symptoms there. It's pretty self-explanatory. They have a sense of doom, feeling choked or smothered, shortness of breath, heart pounding, dry mouth, sometimes dizziness, or feeling like they're losing a grip on reality. Differential diagnoses. Several disorders are associated with fear and avoidance of situations and stimuli. So you want to make sure you're evaluating their targeted fear, their reasons for avoidance, and the range or actual numbers of the situations that they are afraid of. And an individual with a specific phobia does not typically complain of generalized anxiety, and they actually tend to have insight into their irrationality of their phobia. So they're very aware of what they're afraid of. Treatment involves psychosocial interventions, of course, pharmacotherapy, and exposure therapy. Exposure therapy is the first line of treatment. They're going to want to have in vivo live exposure to the feared stimulus. Sometimes they do a virtual reality type of exposure therapy where the person's exposed to a virtual environment such as fear of heights and flying. The biggest thing here with exposure therapy is to make sure that the sessions are spaced close together. The exposure to the stimulus needs to be long in duration. You need to make sure that the person is unable to use avoidance strategies such as distraction or having a partner with them during sessions. It's always best to use real life exposure versus using their imagination. Therapist involvement is very important, so it's good to have a good relationship with the person. And in our book, it said that computer administered treatments have been shown to be successful for specific phobias such as arachnophobia. Pharmacotherapy for non-specific phobia, Lexapro and Paxil, has been shown to reduce distress associated with specific phobias. and reduce other SSRIs or the same SSRIs reduce panic sensations for situational phobias similar to panic disorders such as claustrophobia. The course of illness, some resolve without treatment, such as childhood phobia of animals that sometimes tends to just resolve on its own. Phobias that continue well into adolescence are less likely to resolve. Spontaneous remission is very rare in only 10% of people with phobias. Exposure therapy, as I said, is the best treatment, and pharmacotherapy really doesn't have lasting benefit for phobias. Again, it's that exposure therapy that's really going to target the behavior and the fear. Next, I'm going to talk about generalized anxiety disorder, or GAD. This includes excessive anxiety and pervasive worry present for at least 6 months. It is characterized by fatigue, restlessness, irritability, poor concentration, muscle tension, and poor sleep. Hypervigilance and somatic symptoms can also occur. Impaired cognitive functioning in interpersonal roles, social and vocation. There's a diminished sense of well-being, quality of life, and good health. And patients tend to worry about everyday things, anything and everything pretty much. They can catastrophize pretty much, such as being accepted in social situations, having to confront others. Are they competent at work or certain situations? They worry about their family members and relationships, health, being to work on time or showing up on time, finances. The degree of worry is usually out of proportion both to the chances that something bad is going to happen and the actual impact if it does happen. So it's a pretty exaggerated, it's going to be pretty exaggerated, kind of sort of freaking out about the worst possible case scenario of what could go wrong. There's emotional intensity, poor understanding of their emotions. They tend to have more negative reactions to emotional experiences. They're less able to self-soothe. They have greater difficulty managing their emotional reactions, and again, that emotional dysregulation. Epidemiology, prevalence is about 6 to 8% in adults and 3% in school-aged children. Onset occurs in adults typically after the age of 20. In children, it's between the ages of 8 and 9. It says in our book here, basically, generalized anxiety disorder can follow an episode of depression or any negative event that occurred in the year prior to the onset. It can also develop during pregnancy and after birth of the first child due to increased responsibilities and a desire to be perfect. The severity can increase if it's actually present prior to pregnancy or postpartum. Late onset after age 50 can be as high as in 20% of adults. It occurs twice as often in women than in men. Cultural specifics here, anxiety can be described as nerves or manifest as somatic complaints. In some cultures, people can be viewed as weak or less valued by their family. Now, there's a plethora of risk factors for GAD. Increased amount of stressors, medical illness, losses, history of emotional and physical trauma. Our book had said something about smoking and diabetes can put people at risk for anxiety, being recently separated, divorced, or widowed. You're having personality traits, people who are very shy or timid or inhibited have a higher chance of developing anxiety disorders or GAD. There's a low tolerance for uncertainty, low levels of cognitive function in childhood, behavior problems, high arousal coping style to manage stressors, or minor stressors. And sometimes people have a history of where they have parents who are very controlling and excessively protective. Etiology isn't very well understood. There's various theories here. There's a genetic theory, attachment theory, avoidance theory, and psychoanalytical theory behind GAD. There's an inheritability component of about 22 to 37%. So there's some genetic influence that's combined with stress exposure during early brain development, and this creates a neurobiological vulnerability to stress. The attachment theory involves having insecure attachment patterns. For example, a mother who is unable to or unavailable to soothe feelings of distress for an infant or their child due to her illness, depression, drug abuse, separation, and other causes. The child may then have anxiety problems during childhood that lead to GAD in adulthood. There's the avoidance theory, which builds on the attachment theory in that the insecure attachment patterns, early life traumas, and poor interpersonal skills underlie the development of GAD. There is intolerance of uncertainty theory, where any situation or events that are uncertain, people develop maladaptive ways of coping and are very worried if there's low predictability. There's a lot of pessimism about problem solving that leads to positive results, so they're very pessimistic about the possibility of there being any positive outcome for certain problems they have. Psychoanalytical theory, of course, kind of goes back to Freud here with the id, ego, and superego during childhood, where there was unresolved unconscious conflicts. Biological basis, the brain sort of views ambiguous or neutral information as threatening or negative. More attention is focused on potentially threatening information rather than positive information about situations. Issues with memory and attention can also occur. There's idea here that there's abnormalities in the occipital lobe, basal ganglia, limbic system, hippocampus, brainstem, and frontal cortex. There is studies that have shown that there is sustained activity in the medial prefrontal area after a threatening stimulus was terminated, so that area is still continuing and active even after the threat is gone. The medial regions of the frontal lobe is activated by worrying. Neurotransmitter involvement includes GABA, norepinephrine, serotonin, glutamate, and that's a difficult word for me to pronounce. I'm sorry about that. It's the cholecystokinin, and other hormones like cortisol causes an increase in anxiety in the form of agitated arousal that leads to freezing behaviors. Glutamate processes danger in the amygdala. There's abnormal levels of serotonin, and we all know it regulates mood, impulse control, sleep, vigilance, memory, and processing anxiety and fear. Norepinephrine tends to be increased. So clinical presentation, there's often, as I mentioned earlier, excessive worry that causes serious distress. It's very difficult to control and often interferes with daily activities. I sort of mentioned these physical symptoms: headaches, muscle pain in the back, muscle tension, sleep disturbances, anxiety for at least half of the day. Primary area of worry is on interpersonal issues. Sometimes people with GAD also tend to describe themselves as being the nurturing partner in the relationship, and they actually tend to be more exploited. So it sounds like sometimes they have poor boundaries as well. Let's see here. They also may have a history of early anxiety, social isolation, academic difficulties, obsessions, and disturbed family situations. They've often have a history of trying various treatments, and they're ashamed or embarrassed of their inability to control their symptoms. They have a need for perfection and control. They tend to believe they're responsible for any negative events that occur. Some people worry that their worry actually prevents bad things from happening. So they actually believe their worry is a good thing. And again, it goes back to that cognitive, maladaptive way of thinking, that they're thinking this is working for them, but it's actually really not. 90% of persons with GAD have at least one other psychotic disorder. I thought that was interesting. 2/3 have co-occurring major depressive disorder, which increases their risk for suicide. 1/4 of them have co-occurring panic disorder. 1/3 have a co-occurring alcohol or drug abuse. There's also comorbid personality disorders where they're avoidant, dependent, and obsessive compulsive. There's co-occurring medical issues such as migraines, asthma, as I mentioned, diabetes, hyperthyroidism, rheumatoid arthritis, peptic ulcer disease, irritable bowel syndrome, and CAD, coronary artery disease. Differential diagnoses. You need to make sure that you're looking at whether or not a person is just a really high-level worrier. You need to look at any medical causes and possible, of course, other psychiatric disorders. Our book did mention that high-level worriers do not meet criteria for GAD, and they are less impaired by their worrying. People with GAD tend to experience less control over their intrusive thoughts. They're less able to control their negative thoughts, and they have high levels of somatic hyperarousal. A big medical diagnosis to consider is, any cardiac, pulmonary, any medical disorders, but hyperthyroidism needs to be looked into as well. Okay, so when you're looking at medical conditions, people with, if it's a medical problem that causes the anxiety, there's typically not a family history of GAD. There's no increased life stressors. There is not situational avoidance, and there's no history of poor response to anti-anxiety medications. So, I'm sorry, they have a poor response to anti-anxiety medications. Other diagnoses to consider for psychiatric disorders would be OCD, panic disorder, major depressive disorder, social phobia, other phobias, adjustment disorder with anxiety, social anxiety disorder, non-pathological anxiety and substance-related disorders. So treatment is geared towards the immediate goal of improving symptoms, and the long-term goal being, of course, remission. A couple of assessment tools that are helpful is the Hamilton Anxiety Rating Scale or the GAD-7. Psychotherapy is beneficial. Patients with GAD tend to misperceive events and exaggerate difficulties. They tend to make pessimistic assumptions based on very little evidence and have automatic thoughts that they need to, through CBT, I think, grow an awareness of those thoughts and recognize their cognitive distortions. So CBT is known to reduce anxiety and worry, and it's the first line of treatment. People have been known to show a 30 to 60% reduction of anxiety symptoms. Cognitive restructuring, relaxation, worry exposure, behavior modification, and problem solving are helpful. And after about 6 months of weekly sessions, patients often report benefit. There's also insight-oriented therapy, supportive therapy, mindfulness, meditation, and acceptance-based techniques are also helpful. Pharmacotherapy addresses reducing symptoms of anxiety, but of course not worry. Medications don't fix our thoughts. SSRIs, SNRIs are the first line. Benzodiazepines, of course, probably more of a short term there with the benzos. Buspar is more of a long-term acting anti-anxiety. Anticonvulsants and low doses of atypical antipsychotics are helpful. Psychosocial interventions, of course, promoting healthy lifestyle practices, relaxation therapy, exercise, and self-help interventions. Other things known to help with GAD is yoga, and this, I'm not sure how to pronounce this, balneotherapy. It's a sort of mineral water therapy that is in a spa setting. And I looked it up and I thought it actually sounded pretty interesting. It was the first time I had heard of that. So that has been known to be helpful. Course of GAD, symptoms tend to fluctuate and persist throughout the lifespan. Less than a third of people experience spontaneous remission. 80% of patients continue to have symptoms that interfere with functioning, particularly work. And of course, the worrying tends to have a negative effect on their relationships in all of their life domains. So the next anxiety disorder I'm going to talk about is social anxiety disorder. Social anxiety disorder is a response to a perceived threat to one's reputation or social status. A core feature of this disorder is it's a serious fear of being evaluated by others, being judged as inadequate, and rejected. Person often experiences embarrassment in social situations or when they have to perform in front of people, such as speaking or just really being in front of people. Situations where they might be embarrassed involves meeting new people, dealing with people in authority, attending parties. They're afraid to go to meetings. Job interviews are very stressful. Speaking in front of people, eating in front of people, and using public bathrooms. 25% of patients with SAD have non-generalized SAD, which occurs in one situation only, such as speaking in public, I should say. I think speaking in public is different than public speaking, although, because I think it's a huge fear for people is public speaking, for a lot of people that just have a hard time with public speaking. But this is more so just any situation where you kind of have to speak in front of a group of people for whatever reason. 75% of generalized SAD have generalized SAD, in which nearly all social situations are stressful for them. They tend to, with the generalized SAD, have more symptoms of depression, overall distress, anxiety, impairment in functioning, fewer social skills, and greater degree of self-criticism and fear of negative evaluation. They're also more likely to be unemployed. Key symptoms here, they have, of course, anxiety. Somatic symptoms include tremors, dry mouth, sweating, and blushing. Blushing is a big common symptom for people with SAD, and they're often very embarrassed of even blushing. They also have cognitive distortions where they evaluate their own performances in social situations very negatively. They discount any positive interactions. Basically, they discount any competence they have during any social interactions. Like they'll find negative reasons or come back from a social interaction or situation and be really hard on themselves or critical of and rethink what they said or how they said it and not view themselves as competent when really there was probably no major problem. Where was I? Oh, sorry about that. I skipped ahead. Severe forms lead to unemployment due to fear of interviewing. So some people have it so bad that they don't have a job because they're too afraid to interview for a job. Their social interactions are very limited to family only. They have a diminished quality of life and an increased risk of suicide. Epidemiology. Prevalence is about 4 to 13% of adults and adolescents. The onset begins in mid-adolescence following childhood. In childhood, they're very socially inhibited or shy, or it occurs following an exposure to a very stressful or embarrassing situation. The mean age of onset is 15 years of age. Treatment tends to occur 12 years later. 80% of people never really receive treatment. That's not really surprising when you think about it. If they're socially anxious, they're not gonna want to seek people out for help, and they're embarrassed to even ask anyone for help. Gender occurs more frequently in women who are single, unemployed, are low income, and have less education. More than half of patients never completed high school, and a fifth of them are too disabled to work. Cultural considerations. Some people fear that they're going to offend other people in social situations rather than being embarrassed or humiliated. So that's a huge thing to consider too when we're working with people who are from other cultures. We may overlook social anxiety disorder because they're afraid of offending people rather than getting embarrassed, but it's still kind of the same thing. Some people are also, they have a huge fear of failing the family, or basically disappointing the family. A protective factor was noted in our book. If they have a strong identification with their culture, if they really strongly identify with who they are, where they came from, that can be a protective factor. Risk factors. 40 to 60% of people with SAD could recall a traumatic event or incident that led to developing SAD or social anxiety disorder. I'm thinking I probably shouldn't say SAD because that sounds like seasonal affective disorder, but we're talking about social anxiety disorder here. They have a history of inhibited temperament, which includes crying, clinging, or freezing in unfamiliar situations, or just completely withdrawing. They're known to have had ambivalent attachment patterns. They were mistreated in childhood. They had separation anxiety, language difficulties, shyness, problems with school work as a child. Their parents tended to use shame as a form of discipline. Sometimes there's a parental history of psychiatric disorders or social anxiety disorder. There is known to be high parental conflict sometimes, and sometimes during childhood there were frequent instances of relocating. Etiology is not known. There tends to be a familiar pattern among first-degree relatives. This is strong for generalized social anxiety disorder versus non-generalized. Inheritability is about 28%. In regards to temperament or personality causes, inhibited children have biological markers, which I thought was interesting. They have EEG abnormalities. They have been shown to have increased startle responses and increased cortisol levels. Again, there's that insecure attachment pattern. They experienced parental modeling of social avoidance. They were exposed to humiliating social experiences or experienced peer rejection. Generalized social anxiety disorder, they are more likely to have a history of childhood shyness, whereas a non-generalized disorder or social anxiety disorder, they tend to have been exposed to traumatic experiences that actually conditioned their response to new situations. So I thought that was interesting. Biological basis. High concentrations of substances, like if they're using caffeine or carbon dioxide, also plays a role, and then the cholecystokinin. This stimulates the release of adrenocorticotropic hormone and cortisol. There is known to be increased activity of the amygdala and insula, less activity in the prefrontal cortex, which is responsible for evaluating situations, that self-emotional regulation, and inhibits amygdala activity. There tends to be increased temporal limbic activity, decreased basal ganglia, dopaminergic activity, and neurotransmitters known to play a role here is the serotonin 1A. It has diminished binding potential and modulate. It's responsible, of course, again, that serotonin for modulating fear and anxiety. Dopamine is reduced, which is, they're less engaged in reward-seeking and motivation behaviors. So clinical presentation, there's a lot here. Symptoms of anxiety, like as I said, the blushing. There's anticipation and worry about a situation or event weeks in advance. They're hypersensitive to criticism, negative evaluation or rejection. They have difficulty with assertiveness and self-esteem. Sleep disturbance, difficulty falling asleep, and poor sleep quality. Poor social skills. They have a hard time making eye contact, initiating conversation, and responding to others, like knowing what to say to people. They avoid parties. They're afraid of talking to strangers. They tend to have test anxiety or drop out of school. Issues at work. They have a hard time speaking in public. As I said, being assertive. Eating in front of others or using public bathrooms. If they anticipate that they will blush, they may actually go out of their way to sit near a window, wear cool clothing, or avoid hot drinks. And there's also behaviors here with children. 90% of them have sleep problems. They also will try to say that they're ill or sick in order to avoid doing things at school that they're afraid of. They don't like to change clothes in front of others. Comorbidities, they often tend to have other disorders, other anxiety, mood, substance-related disorders, eating disorders, and avoidant personality disorder. So differential diagnosis. People with SAD, worry. Okay, so you have to determine whether or not they have SAD, because or if it's avoidant personality disorder. People with avoidant personality disorder tend to fear that something is going to be done to them. Or people with schizophrenia or paranoid disorders as well. They're afraid something's going to happen to them or is going to be done to them, whereas people with social anxiety disorder, they are very worried that they're going to do something wrong and be humiliated or embarrassed. Another thing to consider is shyness. Social anxiety disorder is often mistaken for shyness. Shyness has many symptoms of social anxiety disorder, but it differs in the severity of the avoidance, impairment, the course of duration, and social anxiety disorder is very chronic. Although many shy people do meet criteria for social anxiety disorder and avoidant personality disorder. 53% of women and 40% of men who are shy tend to develop anxiety disorder, with social anxiety disorder being the most common. It actually occurs in only 4 to 13% of the entire population. So diagnosis here to differentiate. There's some overlap here with performance anxiety, stage fright, pervasive development disorders, schizoid personality disorder, panic disorder with agoraphobia, and separation disorder. Treatment is focused on reducing or eliminating symptoms of fear, the avoidant behaviors, and the physiological distress to improve function and quality of life. There's a couple of assessment tools here. The social phobia inventory, or the mini SPIN, was mentioned in our book. Psychotherapy. Basically, psychotherapy is going to help when people view social situations as dangerous because they think they're going to be judged. They develop a negative image of how they appear to an audience, or a very exaggerated image of what the audience expects. They're very hypersensitive to any sign of boredom or lack of acceptance from their audience, lack of interest, and aware of their internal sensations of distress, which influences their actions in the future when they're in front of an audience or, at a meeting or whatever. So treatment, again, back to what I was saying here, is treatment's geared toward exposing them to the stressful social situation and that cognitive restructuring that allows them to re-examine their thoughts about themselves and others. CBT is very helpful, exposure therapy is very helpful, self-help interventions, interpersonal therapy, and psychodynamic therapy are all going to be very helpful. Pharmacotherapy is also beneficial. The SSRIs and SNRIs are the first line. Benzodiazepines can be helpful for the generalized social anxiety. Beta blockers or benzodiazepines are very helpful for the non-generalized social anxiety and for performance anxiety. Psychosocial interventions, the focus here is going to be social skills training, and relaxation strategies. The course is lifelong. Half of the patients recover. Outcomes are less favorable, of course, for anyone with comorbidities, personality disorders, depression, or other anxiety disorders. So next I'm going to talk about panic disorder. So they tend to occur, basically panic disorders is having panic attacks that occur repeatedly with concern for any future attacks that might happen. So the person will avoid any situation or trigger where they're going to have another panic attack. Panic attacks are considered to be biological events that are caused by brain dysfunction. There's an abnormally sensitive fear network in the brain. 20% of the population have panic disorder, and panic attacks occur in other disorders such as social anxiety disorder, PTSD, specific phobias, mood disorders, and substance-related disorders. Symptoms: feeling lightheaded, smothered, chest pain. Chest pain's pretty common. Nausea, numbness, chills, palpitations, pounding heart, dizziness, sweating. There's a sudden onset of intense fear, a sense of doom in the absence of real danger. So you feel like you're going to be attacked by a lion, but there's really no lion there. There is a sense of derealization or depersonalization. They tend to feel as though they're having a heart attack or are about to die, or they're about to have a breakdown, like they feel like they're going crazy. Panic attacks typically last about 5 to 20 minutes, with the peak anxiety occurring 10 minutes after they first started having symptoms. Again, they develop anticipatory anxiety about future attacks and will do anything to avoid the stimulus that they think may trigger future attacks. And sometimes they think that they associate certain things that triggered an attack, but it may not really be that whatever it is, like if they have a fear of like loud sounds or something, but really it could have just been something else. But I don't know, sometimes they're very well aware of what their actual triggers are. So they also may develop agoraphobia. So it's characterized, people with panic disorder tend to abuse substances. They have overall diminished, poor quality of life, increased risk for suicide attempts, poor physical health, impaired occupational and social functioning, concern about the consequences of having panic attacks, and again, they're just very worried about future attacks, recurrent and unexpected panic attacks. Epidemiology, 2.1% of adults, is more common in non-married persons and less common among those who completed college. The onset in adults is between their early 20s and early 30s. It occurs twice as often in women than men. Women are more likely to have agoraphobia with panic disorder than men. It's more acceptable for women in other cultures to suffer from panic disorders than it is for men. Men tend to hide their fears and have to kind of toughen up and face them. There's a variety of risk factors here that our book had talked about. Being of female gender, middle-aged, widowed, separated or divorced, low income, experiencing major loss or illness, a victim of interpersonal violence or sexual abuse, exposure to stressors such as financial or work problems, moving or starting a new job, any major life change really, or transition can sort of bring this on. Etiology, so there's a genetic influence, a vulnerability. There's a high rate of panic disorder among first-degree relatives, although inheritability is about 43%. Okay, so there's a few different theories here. Well, a couple different theories. There's a developmental theory where a combination of behavioral inhibition and increased arousal and inhibition in unfamiliar situations where there's basically if they're not familiar in a situation, they're more inhibited, they're more intense, more aroused, kind of freaked out with new challenges or any uncertainty. There's the psychodynamic theory, of course, back to the ego again, where the anxiety tells the ego to mobilize or get these defense mechanisms going that include repression to counteract that danger, and this is sort of an attempt to restore balance. Sometimes there were non-supportive patterns of family interactions, prior unsuccessful attempts to manage their anxiety, and again, those life stressors can reactivate a fear of being abandoned and fear of loss of relational attachments. Factors that they experienced, a lot of times they have a high rate of adverse life events that occurs or occurred months before their actual first panic attack. Maybe they have a death or loss of a loved one, high marital conflict or miscarriages. Again, a biological basis here with this disorder. There's known to be structural, functional, and chemical abnormalities in the brain. The structural involves amygdala, hippocampus, and brainstem. There's decreased density of neurons in the parahippocampal area, which is involved in learning, emotions, and social behavior. There's also decreased volume of the amygdala and increased density of gray matter, the gray matter volume of the brainstem that controls breathing. So there's greater activity in this area, which is kind of interesting. Functional abnormalities. There's some sort of, I had a hard time really understanding this, wrapping my brain around it, but there's the carbon dioxide hypersensitivity here, where there's some sort of faulty suffocation alarm system in the brain that misinterprets situations. There's a huge role here with the brain stem and breathing, where there's irregular breathing patterns, and a panic attack occurs as a result due to an exposure of carbon dioxide, which leads to this transient cerebral hypercapnia. Is kind of interesting. Some people think hyperventilation causes panic attacks, where it's this consistent short breathing pattern, but it's actually the irregular breathing pattern that occurs. Chemical abnormalities, GABA and the serotonin 1A receptor and benzodiazepine receptors here have a role. If GABA is low in the brain, then you're going to have high glutamate levels, and this is going to cause hyperarousal, restlessness, kind of a keyed up feeling, anxiousness, and insomnia. So the serotonin 1A receptor, there's a reduction by 30% of this receptor, or density of this receptor, in the part of the brain that regulates anxiety. And then there's a 41% reduction of these receptors in the midbrain, where this receptor or the serotonin is synthesized and released. So I thought that was interesting. And then with the benzodiazepine receptors in the brain, for some reason they're unable to bind to GABA in the brain, and therefore you're going to have less GABA. So of course, when you have less GABA, you're going to have less calm. You're going to be less calm and more anxious. Clinical presentation of a panic attack. You're going to have 5 stages. There's the subpanic stage, where you're rapid heart rate, shortness of breath, and lightheadedness. Then there's the panic attack stage, where there's the freezing or flight with fear of loss of control. The hypochondriasis stage, which is the fear of panic symptoms relating to a physical illness. So people get really like, oh my gosh, I have this illness and I need to be tested for this, and I need to have this, and I think this is wrong with me physically. So they tend to have multiple ER visits. They've seen many doctors before they're actually diagnosed with a panic disorder. And they've often consulted with many psychiatrists when they're in this hypochondriasis stage. There's the anticipatory anxiety stage, of course, again, where they're afraid of future attacks, and then the phobic avoidance, where again they avoid that situation or place where that stimuli may be, where they have no escape, where they have that. It's called agoraphobic avoidance. Panic disorder, again, like I said, patients often go to the emergency room thinking they're having a heart attack. This is known to make up about 20% of emergency visits per year, I think is what our book had said. Panic attacks here will reoccur once or twice a week, leaving the person drained or completely exhausted for up to 2 days. 70% of patients have contacted at least 10 doctors before a correct diagnosis is actually made of panic disorder. And they can be sick for about 8 to 10 years before they ever seek treatment. So they're pretty miserable. High rates of comorbidities, again, really medical disorders. They tend to have a lot of medical stuff too, which is interesting. Sometimes you don't really know what comes first, so you have to get to the bottom of that. And then, of course, other psychiatric disorders. So other differentials to consider here for diagnoses, again, consider underlying medical conditions, co-occurring, if they're using substances, other psychiatric disorders such as separation anxiety disorder, avoidance that occurs in delusional disorder, social phobia, the avoidance that occurs in OCD, and somatization disorder. Treatment addresses the panic attack symptoms, anticipatory anxiety, phobias related to panic attacks, and impaired functioning and well-being. There's a few assessment tools here that I listed You guys can take a look at that. Psychotherapy is going to be a combination of that in vivo exposure therapy, CBT, psychodynamic therapy, and supportive therapy. Medications are going to reduce or eliminate the panic attacks, avoidance, and anticipatory anxiety. There's first line, second line, and third line therapies, augmenting medications, and long-term and combined pharmacotherapy. Again, those SSRIs and SNRIs are first line, TCs are second line, and benzos are third line, although contraindicated in substance abuse. Venlafaxine, Buspar, and Zyprexa tend to be good augmenting medications. Psychosocial interventions are aimed at here panic controlled treatment, marital and family therapy, this bibliotherapy mentioned in our text, education, and self-help interventions. The course is very chronic and debilitating, more so than even some medical illnesses, so it can be very, very, very difficult for the person who has panic attacks. 30% of patients who actually receive treatment do well, so it's not a whole, a lot. 40 to 50% show some improvements, but some still continue to have some symptoms. 20 to 30% have the same or worse symptoms, and for those who achieve remission, approximately half relapse within 2 years despite them continuing treatment and doing everything that has been helping. So that concludes the anxiety disorders, a review of the anxiety disorders. So Peplau, we're going to move on to Peplau's theory. So she's one of our nursing theorists here who her theory and concepts were heavily influenced by this Harry Stack Sullivan. I haven't personally read much about him, but I guess there was some sort of Sullivanian therapy that she really, really liked and incorporated some of those things into her theory about anxiety. It's heavily based on interpersonal relationships. She believed that tension, anxiety, and frustration are felt when human needs are not met and relationships are disturbed. She believed that behavior is a result of our interactions and relationships are based on unmet needs. The anxious behavior, whatever, is a result of unmet needs. When needs are not met, she says that more mature needs cannot even emerge. So if your basic psychological or various whatever needs are not met, like ever by your, let's say in early childhood, by your caregivers, there's sort of a stunt in development and growth here, so that these other more mature needs are never really going to emerge, because by the time you get into adulthood, you're still like trying to meet these almost childhood psychological needs. So it's kind of interesting. Back to what she said here, frustration can occur and serve as a threat to the personality, and all that behavior is going to be geared toward getting that need met. She believes that nursing practice occurs within a relationship between, the nurse and the patient, and the goal of the nurse is to assess the interpersonal interactions that take place between the client and others. This is going to help identify their human responses and problematic patterns, and that we need to make sure we're listening to the facts that the patient presents, and while we're doing this, we're going to observe their body movements and gestures. The interventions are aimed at establishing and maintaining, again, that goal-oriented relationship with the patient and help them reach his or her capabilities. Major concepts and unmet expectations. So the major concept with her theory is the self. It is this abstract thing that is revised throughout life during interpersonal relationships. There's the self view, how a person views one's self, which is made up of baseline appraisals from caretakers early in life and subsequential life experiences. There's the self-image, or the ideal of oneself, that is conveyed to the world. Self-worth, which is a result of the close relationships we have that provide validation. and is outside of the family. Self-esteem, the level of confidence a person has in his or her abilities and is measured by an ability to self-praise. So there's these unmet expectations that occur, and they're perceived as a threat to the self system, which are her major concepts here. So expectations, everybody has these assumptions, wishes, wants, beliefs, hopes, desires, goals, and expectations are considered to be situational, sociocultural, personal, or a mixture of the three. Again, unmet expectations are considered to be a threat to the self and requires immediate behavioral response to restore comfort. So again, there can be maladaptive ways or adaptive ways of getting those needs met. So if the unmet expectation is perceived as a threat to the security of the person, then you're going to have this anxiety that happens. So she continues to say in regards to this anxiety that it's a response to an unknown danger that is experienced as discomfort and arms the human being for using resources to meet the difficulty. So the behavior response can occur in adaptation, personal growth, learning, or in maladaptation and illness. And anxiety is often the first step to problem solving, and then the person focuses on all of their resources to meet that need. So she says anxiety occurs on a continuum. There's mild, moderate, severe, and then panic. Of course, you have mild, which alertness is going to be increased. Learning processes are functional or operative, and problem solving can still occur, and connections can be seen. Moderate, the perception of the person narrows and selective attention occurs. Severe, there's going to be a greater focus on detail, or the person's going to be more scattered with details. There's going to be a selective attention, and the view of the problem is really narrowed. There's this panic level of anxiety, again, where you have that terror feelings. Details are blown up with the inability to really see reality. So it's this distortion again happening, and behaviors that focus on obtaining relief. So behavioral responses to anxiety, the main thing here that Peplau said is that the behavior is going to be used to try to transform this huge energy of anxiety. So they can either act out, which can be overt, such as anger, or covert, such as being resentful or holding grudges. So there's this kind of energy that's just kind of sitting there. Somatizing, if I'm pronouncing that right, manifests in psychosomatic complaints. This anxious energy can result in freezing on the spot or withdrawal, or it can be used in the service of learning. The person uses that energy, that anxious energy, uses learned processes to acquire a new knowledge or skill. So things to assess when you're dealing with somebody with anxiety is you're going to want to find out the description of the situation that precipitated symptoms. You're going to want to know their present level of anxiety, the subjective, and then note your objective information of their communication. 3, you're going to want to know their previous experience with similar situations and how they handled it. You're going to want to know situations that escalate anxiety for them, when this happened, where it happened, feelings they had before they had the anxiety. You're going to want to look at their cognitive abilities, like what is their level of reality or distortion? What is their ability to problem solve? And what are their thought processes that go into this? You're also going to want to take note of the physiological manifestations, like the symptoms. Psychological manifestations, indecisiveness, oversensitivity, tearfulness, agitation, powerlessness, low self-worth, being very tense. And what are their relief patterns? What is the sequence or relief behaviors? I'm sorry. What are their patterns of behavior, the sequence and types of behavior? Again, the degree of the anxiety or severity, and know what your actual level of anxiety is about the patient. What are your feelings about the patient? So some responses to anxiety that they may have include their potential for self-harm or harming others. They have a decreased ability to problem solve. There's physiological disturbances, obsessive behavior, compulsive behavior, or phobic behavior, which is, again, all a way to try to adapt to this anxiety and cope with it, whether it's adaptive or maladaptive. And then nursing interventions are going to be geared towards, again, establishing that therapeutic relationship. You're going to want to try to find ways to reduce the anxiety so learning can occur, help them understand how their anxiety in general and how to be aware of it and how to relieve it effectively and positively. You're going to want to teach them about how their unmet needs or expectations leads them to having these behaviors. Again, like I said, be aware of your own anxiety. When you're interacting with them, you're going to want to be calm and be very non-judgmental. Help them compare their self-expectations to realistic expectations. Help them verbalize a threat to his or her sense of security, and help them, again, like I said, plan realistic goals for the future. So there's an example in our Ziegler book of a case. So you can review that in our book, and then basically our book breaks down how to formulate a care plan for this person who had anxiety, and that's on pages 187 to 194 if you're interested. And so here are my references. And this concludes my presentation. Thanks.